Welcome to the deep dive. This session is designed as your rapid deployment kit for the neurology clerkship.
Mm-hmm.
You're moving past the lecture hall and into patient care. And our mission today is to really ground the theoretical knowledge of headache disorders in solid clinical judgment.
That's right. Because when you start your clerkships, you'll see that migraine isn't just a bad headache. It's a major, and I mean major, neurovascular disorder.
And a disabling one.
A very disabling one.
Yeah.
Our goal is to train your ear. The diagnosis, the whole treatment plan, it's all in the patient's story.
So to make this real, let's introduce the patient who will guide our deep dive today, Mary.
Okay.
Mary is 38, a high-powered telecommunications executive, and she tells us she's been suffering from these just debilitating headaches for about 15 years.
A long time.
A very long time. They're getting worse, sometimes knocking her out of commission for a whole day, maybe more. She's here for a real diagnosis and a treatment that actually works.
Okay, let's start with the scope of this. I mean, how common is migraine, really? And what's the striking demographic split we see in the sources?
The incidence is huge. Migraine accounts for something like 16% of all primary headaches. But the key clinical takeaway, the thing you have to remember, is the sex disparity.
Right. It's not even close.
Not at all. The cumulative lifetime incidence is significantly higher in women. We're often talking a 3-to-1 ratio.
And that disparity points directly to hormones, doesn't it?
Absolutely. The condition is profoundly affected by fluctuations in estrogen. It's why patients like Mary so often report a strong link to their menstrual cycle. We call it estrogen-associated migraine.
Which is key for treatment planning, I imagine.
Vital, not just for diagnosis, but for crafting very specific preventative strategies, which we'll definitely get into. Okay, let's zoom in on the root cause. For decades, everyone thought it was just a plumbing problem, vessels constricting and dilating. But that's not the modern understanding at all.
No, the instability starts centrally, in the brain. Fundamentally, migraine is a disorder of the brain's neurovascular control system. The pain cascade begins with a really fascinating electrical event. It's called cortical spreading depression.
Cortical spreading depression, CSD. It sounds dramatic.
Mm-hmm.
How should our listeners visualize this when they're talking to a patient?
Think of it like a slow-moving electrical wave,
Yeah.
a ripple in a pond. It's a wave of intense neuronal depolarization that just sweeps across the cortex at about 3 to 5 millimeters per minute.
And this wave is what causes the aura.
It is the immediate cause of the aura.
And Mary actually experiences this. She describes seeing shimmering zigzag lines.
That's a classic scintillating scotoma. She's literally seeing the CSD wave move across her visual cortex. It happens in about 25% of migraine sufferers. And once that wave passes, it leaves behind an area of reduced neuronal activity, and more importantly, it triggers the next step,
Which is?
activation of the trigeminal system.
So the electrical event kicks off a nervous system response. What happens when that trigeminal nerve gets activated?
Well, the trigeminal nerve starts releasing these potent vasoactive peptides. And that brings us to the final and most painful step, neurogenic inflammation.
This is where the actual throbbing pain starts.
Precisely. The master neuropeptide here is calcitonin gene-related peptide CGRP. When CGRP is released, it causes vasodilation, inflammation around those pain-sensitive blood vessels in the head.
So the instability is electrical, but the pain itself is inflammatory.
You've got it. And that brings us to Mary's full symptom profile. She mentions a prodrome.
Yeah, well, what is that exactly?
That's phase 1. It can happen in a day or two before the actual headache in up to 60% of patients. And the clues are subtle increased yawning, irritability, even euphoria.
And the headache hits.
Then the headache hits, usually one-sided, that classic throbbing quality, and it can last anywhere from 4 to 72 hours.
And it's the associated symptoms that really make it so disabling.
Oh, absolutely. That's the diagnostic clincher. The profound nausea, often with vomiting, plus the photophobia light sensitivity and photophobia, sensitivity to sound. It's why patients like Mary just have to go lie down in a dark, quiet room. So now that we know the mechanism, we can talk about how to stop an attack. And that really relies on understanding the role of serotonin.
Right, 5-HT, it's a huge player in modulating pain in the brainstem. So what was the drug class developed to target this system?
That would be the triptans. For a long time, the absolute gold standard for moderate to severe attacks. They're selective 5-HT1B1D receptor agonists.
And their success comes from a multi-pronged attack, right? There are 3 key mechanisms.
There are. And you need to know these goals for your clerkship. First, vasoconstriction. They clamp down on those painfully dilated cranial blood vessels. Second, they inhibit the release of neuropeptides like CGRP.
Cutting off the inflammation at the source.
Exactly. And third, they work centrally to block the transmission of pain signals in the brainstem. It's a really complete abortive strategy.
This brings us to a huge piece of patient counseling timing.
Right.
What does Mary need to know about when she takes her triptan?
This is probably the single most important principle of acute treatment. Abortive meds work best when you take them early,
Hour and week.
ideally within the first hour. Once central sensitization kicks in, the drugs just become much less effective. And we also advise a single large dose. Don't try to chase the pain with small doses.
So for Mary, a triptan is first line. The sources also highlight a strong benefit to combining it with an NSAID.
That's a powerful synergy. A triptan plus an NSAID, like sumatriptan naproxen, is documented to be more effective than either drug by itself. The NSAID hits the inflammation, and the triptan hits the neurovascular side.
But not every patient can take a triptan. We need alternatives, especially if they have vascular risk factors.
And this is where the field has been totally revolutionized. We now have non-vasoconstrictive options. First up are the CGRP antagonists, which we call the gepants.
Like rimegepant or ubrugepant.
Right. These are small molecule antagonists that block CGRP directly. They are a game changer for patients who don't respond to triptans or, more importantly, have contraindications like a history of stroke.
Then there's lasmiditan, which hits a different serotonin receptor, 5-HT1F. What's its niche?
Lasmiditan is fascinating because it lets us use the central pain-blocking effects of the serotonin system without causing any vasoconstriction. So, another great option for patients with cardiovascular risk.
But there's a massive safety warning with that one, a counseling point you cannot miss.
This is critical. This is a mistake you can't afford to make. Lasmiditan often causes significant dizziness. You must tell your patients, do not drive or operate heavy machinery for at least 8 hours after taking it. It's a huge patient safety issue.
Okay, let's move on to managing nausea. Mary said her nausea is severe, and that's not just disabling, it physically stops oral meds from working.
That's right. Vomiting is obvious, but severe nausea causes gastric stasis. The stomach just stops moving. So that expensive triptan pill you gave them, it is just sitting there.
So treating nausea is priority one. In an acute setting, like the ER, what are we using?
We rely on primary antiemetics, which are dopamine receptor antagonists. The ones you need to memorize are metoclopramide, 10 milligrams IV or IM, or prochlorperazine, also 10 milligrams IV or IM.
And there's a clinical pearl here, right?
A high-yield one. These agents don't just treat the nausea. They have independent efficacy in reducing the headache pain itself. They help break the whole attack cycle.
But giving potent dopamine antagonists parenterally comes with a serious risk of acute dystonic reactions. Akathisia. There's a required safety step.
You cannot skip this step, ever. To prevent those, you must give adjunctive diphenhydramine, usually 12.5 to 25 milligrams IV. Think of it as your insurance policy. If you order metoclopramide or prochlorperazine, you also order diphenhydramine, period.
Okay, so once we've mastered the acute attack, we have to think bigger picture. This brings us to the challenge of medication overuse headache.
This is the bridge from acute to prophylactic care. If a patient is using any acute medtriptans, NSAIDs, whatever, more than 10 days a month, they risk developing medication overuse headache.
Where the treatment starts causing the problem.
It's a vicious cycle. So that's when we have to shift our strategy from just treating attacks to proactive preventative management.
And the indications for that are what? 4 or more headache days a month?
That's a common one. Or if the attacks are just causing significant disability despite acute treatment. Or, as we said, to prevent MOH.
So for Mary, with her predictable hormonal headaches, we might suggest something called mini prophylaxis.
Exactly. For a predictable cycle like hers, you don't need a daily medication year-round. A mini prophylaxis strategy is perfect. You start a long-acting NSAID, like naproxen, or a long-acting triptan, 1 or 2 days before her period is expected.
Then continue for how long?
For about 5 to 7 days total. It minimizes drug exposure, but covers that high-risk window perfectly.
But if that doesn't work, or her headaches become less predictable, we need continuous prophylaxis. What are the big categories?
We try to match the drug to the patient's other issues. So we have antihypertensives, like the beta blockers propranolol or metoprolol. Great if the patient also has high blood pressure. Then there are the anti-seizure medications. Topiramate is often favored if the patient could benefit from weight loss. Valproate if they have a coexisting mood disorder or epilepsy.
And then there are the new options.
The CGRP pathway again.
Yeah.
The monoclonal antibodies erinomab, Fremanezumab or oral Japans like atogepant are highly effective first-line options now, especially for patients with severe disability.
Speaking of the anti-seizure meds, for female patients of childbearing potential, there's a critical safety warning.
This is non-negotiable safety counseling. Valproate is absolutely contraindicated due to significant teratogenicity, a high risk of neural tube defects. And topiramate also carries risks and should be avoided during pregnancy. You have to have the birth control conversation.
Which brings us to our final and maybe the most vital section, the safety checklist. You are about to start prescribing. What are the life-threatening contraindications we have to memorize?
We're talking about the vasoactive agents, the triptans and the ergots. They cause vasoconstriction. So if a patient has a history of vascular disease, you simply cannot give them these drugs. End of story.
So what's on that list? What makes you stop and say no triptan?
Any history of ischemic stroke or TIA. Any history of ischemic heart disease, so an MI or angina. Prinzmetal's angina. Yeah. And of course, uncontrolled hypertension. If you see any of that in the chart, the alarm bells have to go off.
We also avoid them in some of the rarer migraine types.
Correct. Hemiplegic migraine or migraine with brainstem aura, the theoretical risk of cerebral vasoconstriction is just too high.
Okay, drug interactions. What's the main timing rule for triptans?
You must not use a triptan within 24 hours of another triptan or an ergotamine drug. You cannot double up on vasoconstrictors.
And what about combining them with SSRIs or SNRIs? I always hear about serotonin syndrome.
You do, and while the concern is often raised, the actual clinical risk appears to be extremely low. Still, it's something to be aware of. You monitor the patient.
Finally, let's circle back to those antiemetics. We talked about dystonia, but some have a potentially deadly cardiac risk.
That's the QT prolongation risk, which can lead to torsades the point. You have to be extremely cautious with agents like droperidol, haloperidol, and high-dose IV ondansetron. They can prolong the QT interval on an ECG.
And when do we absolutely avoid them?
If the patient has congenital long QT syndrome, or if their corrected QTC is over 500 milliseconds, this is a subtle but incredibly high-stakes safety check that you were expected to make.
So, as our listeners prepare to see patients like Mary, let's review the final checklist for excellence in migraine care.
First and foremost, listen. The diagnosis is in the history. The triggers, the aura, the pain quality, it's all there.
Second, frame the migraine correctly. Educate the patient that this is a real neurological disorder. It helps fight the stigma.
Third, stratify your care. Match your therapy to the severity of the attack.
Don't be afraid to use a combined triptan NSAID for those really bad ones. And fourth, treat early.
Exactly. Fifth, always check those red flags. That vascular contraindication list has to be second nature. And sixth, partnership. This is long-term, it's a collaboration.
Let's think about Mary again, suffering for 15 years. We know chronic migraine, that's 15 or more headache days a month, affects about 2% of the population.
Right. And while about 3% of people with episodic migraine progress to chronic each year, the story doesn't have to end there.
The outlook isn't static.
Not at all. That's the critical takeaway. Reversion, going back to episodic manageable migraine, is possible for a significant number of patients. We see rates from 26 up to 70% in some studies.
And that prognosis depends on two things.
It really does. One, resolving any medication overuse. And two, strict compliance with preventative therapy.
So as you enter the clinics this year, the question is, what specific role will you play in helping a patient like Mary reverse that trend, moving her from chronic disability back to a manageable life? That journey from suffering to stability driven by precise knowledge. That's why this deep dive matters.